with the same idea which I propagated in the last webinar also, is that establishing the orthobiologic science in India, or rather the entire world, and creating the evidence-based environment for everybody so that we can find out the right indications, contraindication, limitations of this science, orthobiologics, so that we can remove the hype about this science and remove the lot of misconception or myth about the science. So with this thought, we have started this webinar, and today's episode is dedicated to orthobiologics augmented rotator cuff repair. We all are aware that rotator cuff repair is a very day-to-day surgery which we do in all part of India or in the world. So how can we improve the outcome of rotator cuff repair? So we have a expert panel. We have our moderators. Dr. Sandeep is here. Dr. Sandeep is our moderator from Mumbai. He is the head of the orthopedics department at Mumbai Port Authority Hospital. Dr. Amit Thakur is there from another part of India, from AIMS, Jammu. He is a professor at All India Institute of Medical Science, Jammu. We have co-chairman of this event, Dr. Daniel Moya, who is a professor of orthopedics in Argentina. And to speak on this topic, we have none other than Dr. Denny Lie, who is a professor at Singapore. Dr. Sandeep will introduce him formally. So without wasting much time, I'll hand over the proceedings to Dr. Sandeep. Over to you, Dr. Sandeep.
Thank you, Dr. Karun. And it is very much pleasure. Thanks to you and Professor Daniel Moya and all the organizers, and also my fellow moderators, Dr. Amit Thakur. So I would like to introduce speaker for the evening, Dr. Danny Lee, who is going to speak on orthobiologics, augmented rotator cuff repair in this season 1 and episode 3 of orthobiologics webinar. So, Dr. Danny Lee is Associate Professor and Senior Consultant at Department of Orthopedic Surgery, Singapore General Hospital. He is a Program Director in Sing Health Orthopedic Residency. He is Director of Rebel and SID Biomechanics Lab. He is the past President of Singapore and Asian Ortho Association, Asian Shoulder and Elbow Association. He is currently Asia Pacific Orthopedic Association Executive Council member, and he is the Executive Council member for the ISAPA Shoulder Committee. committee. So it is a great pleasure to introduce Dr. Danny Lee. Over to you, sir.
So,
Good
Dr.
evening,
Danny.
and thank you, Dr. Sandeep, Dr. Jain. Thank you very much. So to our listeners, good evening, and thank you for listening into this session. It is indeed my privilege to be able to share with you some of the things we do here in Singapore. If you permit me, I will now share my slides, and we can begin this discussion.
Yeah, please go ahead, sir.
Yeah. My slides visible?
Yes.
Yes, sir.
Please make
So
it
good
full
evening
screen.
again. Today we'll share with you also biologics in cuff repairs. So as we know that as we go along, everybody's excited. It seems to be a new paradigm in every 5 to 10 years. But really, is it a passing fad or is it something here to stay? So that's what I'll share with you. So I thank Dr. Jain and team for inviting me for this session. When I received this invitation, I was pretty excited. And I thought 8 p.m., that's a good time, just after my dinner. And then I realized it's 8 p.m. India Standard Time. So it's 10:30 p.m. in Singapore. Thank you very much. Happy to share this Thursday evening with you guys. Late or early, welcome to Singapore. Welcome to visit us anytime you want. As you know, we are a small city state, Southeast Asia. But yeah, happy to share with you and welcome all of you. As you know, I work in Singapore General Hospital, and we started off as a British Army hospital a long time ago, and now we are fairly big. So this evening, I'll share, by way of introduction, why some cuff repairs can fail, and why perhaps biologics is the missing puzzle to all that. There is a mechanical model that I've been trying to study, and I realized that it can't answer everything. And so we come to biologics, and I'll share with you 4 techniques, 4 things that we've tried. PRP gels, Regeneten, ADMs, and the latest thing, BioBrace. They're not just surgical techniques. They're not just tools or toys that we play with, but each one represents a development in our thinking, our trials. Yeah. And so we start. So healing in cuff repairs, can biologics help healing? So despite our best intentions, despite our best techniques, rotator cuff repairs do fail, as low as 20% in medium tears and as high as 60% in massive cuff tears. It is known that the most common reason perhaps is suture pull-through at the suture tendon junction. And therefore, the possible reasons for failure could be, in the very first place, the large tear size, the delay or longer time to surgery, poor hosts, poor tissue quality, poor techniques, and perhaps atrophy of the muscles. More and more, we are thinking that the entire tendon muscle complex is one unit. And therefore, it's not just mechanics. Yeah? We really need to look at biologics. We know that healing is more than just anatomical restoration. It is the creation of a favorable biological environment that will help healing. And therefore, these biological factors are predictive. Old age, DM, smoking, hyperlipidemia, gout, large tear, fatty degeneration, and so forth. So we know this, but what can we do about this? So this is part of the mechanical model that we've been working with. We've tried to look at morphology of tears. We've looked at strength of anchors. We've looked at techniques of repairs. Then I looked at anthropometry of our Asian cuff tendons, studying the material and strain profiles. I've looked at contact pressures and anthropometry, and we've published these. But to me, if I put all these mechanical factors, can I be predictive of healing? And you know the answer is no, because really the hidden factor is biology. Well, biology may not be everything, but it really improves the healing potential, and it helps to reduce re-tear rates. So I think it's here to stay, and we really have to explore this area. We can't be afraid of it, but let's look at the ways of these augmentation. And these are, one, growth factor or cytokine based, classically is PRP. Two, stem cell based, like BMAC or bone marrow stimulation. And three, scaffolds. Unfortunately, stem cells is not fully legislated in Singapore. So all I could do is PRP, either injections or gels, indefinitely scaffolds, which is where we are working on. So I'll start off with the first technique. This idea of PRP, can it improve rotator cuff repair? If we look at the literature, there are many out there. So I'm just quoting two of these. This one was a meta-analysis way back in 2020, how they applied PRP, which we know is rich in growth factors and cytokines. And they showed that in the various studies they compiled, a decrease in re-tear rates, and certainly an increase, an improvement in short-term constant scores, UCLAs, and VAS. So PRP seems to work in this study. This study by Pietro Rondelli is using 6 mils of PRP in 53 patients suggests the pain score was lower in the PRP group. Other prompts are also improved in them. But you know, sometimes literature is a little bit skewed. We can select what we want to prove. As many as there are studies that support PRP, there are others, most of them perhaps, show that it is perhaps equivocal. It may or may not improve. So it's not really universally accepted. But my challenge is that I think PRP injections, which we used to give, during the time of surgery can be washed away or suffers from the dilution effect. If you think about it, you really want to concentrate the PRP at the tendon bone junction right where the anchor is, that's where healing takes place. That's where it's most needed. That's why in our journey for PRP, I decided to gel that PRP, and I want to tuck it in right at the repair site. The next few slides shows you how I do it. So this was a standard 60-year-old female, right shoulder pain. Pain was at night, yeah, no recent injury. And physical examination, not too unusual, rather unremarkable, except maybe painful Jobs, Hawkins, and speech tests are positive. Weakened power, secondary to pain. Yeah. So when we look at the X-rays, they look really quite normal, mild degeneration, and scan shows a bursal-sided partial thickness tear at the anterior fibers. Nothing unremarkable. But this one, because of her age, and age is one of the factors we've seen that may predispose to weakened tendon or degenerate tendon, I decided to do a PRP gel. We prepared a PRP in a standard way, except that we activate it in order to make it gel-like, yeah, using calcium gluconate. So we mix this and it gels. The challenge is, how do we make the shape of the gel? So I realized that I can shape it to where the tear, what the tear looks like. In other words, the morphology. So I use simple containers like this, cutting them to shape. How can I deliver the gel in a very safe way? Because like the PRP injections, the gels can float away. You pretend we tuck it in and then you run the water. Many times it kind of floats away. In fact, one of the techniques, I think one of the companies proposed a bursal augmentation where they just inject this gel over the tendon. Whereas it's promising, or rather the results, but I'm not sure about the dilution and washing off effect. So what I did was to create what I call a doorstep delivery, where I trimmed the standard Turomo syringe to deliver the gel exactly at the tear. This is how I did it. So this was a classic subacromial decompression. We clear, right, big space, and yeah, debriding the tendon. And remember, the tear wasn't too big, so it was easily controlled. We see that small tear on a weakened tendon, and then I debride that. So this is, I trial using the cannula, the cut to remote syringe. I know I can deliver it right over there. So then I prepare my sutures first. I pass horizontal mattress sutures, both anteriorly and then posteriorly. So everything is prepared first. Yeah? 2 horizontal mattress sutures ready to be tied down to the lateral row. So the trick is, just before we anchor down to the lateral row, that's when it's delivered. Everything is prepared. Yeah? And then I dry scope, stop the fluid, and once ready, that gel is delivered. So even if I run the liquid medium, and if I have the cannula, the Turomo cannula, I insert the gel right at the tendon healing junction, and then I hammer down the lateral row. Yeah. So right at the tendon junction, you can see a little bit of tendon of the PRP gel sticking out there. So then I check, was there other techniques? This one from Korea does almost the same way. They use a PRP gel, they string it into a string like that. And then as they pass through the tendon, the gels get collected there. So there's a way to hold it down. Okay? So many ways to deliver what we believe that the PRP concentrate and the gel right at the healing site. So right now we're still tracking our outcomes, whether they would improve significantly healing rates. So the take home is a novel technique of delivering PRP gel right at the tendon bone interface where healing will take place. This, I believe, would avoid the dilution effect of pure PRP injections or just plonking the gel there where it can easily float away. So these are one of our thinking about how I use PRP. But we move on very quickly to the idea of scaffolds. How can scaffolds improve our healing? We're all aware of Regeneten, and I show you just to make a complete repertoire of all the scaffolds that are available. But personally, I stopped using Regeneten because of its weakness at time 0, although biologically it is known to be very good. Regeneten is a bioinductive collagen patch, a bovine Achilles tendon. It's highly porous and induces native tissue growth. It improves the availability of type 1 collagen. And so, over time, because of that incorporation, it increases the tendon thickness, strength. And SNN's own internal studies seem to show very good outcomes with reduced retear rates. So its deployment is actually very easy. We had a mini series, but again, I must share that we kind of stopped it because of its high costs. So these cannulas are positioned into place, and then the Regeneten is deployed by sliding away the cannulas and then deploying it. A very nice way of deploying. It springs open, yeah, into unfold it there, and you hold it in place. You can use additional instruments to keep it in place, and an additional portal to be able to access to all the corners of the Regeneten. These corners are then literally stapled down using this blue partially resorbable anchors or staples. So at two ends with various portals, we can deploy them, yeah, and in the middle as well. And then the lateral aspects of the Regeneten, we put more of these staples. The edges as well. And the nice thing is actually it's very easy to apply them, and you can put it anywhere you want. These are the stronger staples for the lateral bone junction. So these go down right to the bone. So it looks something like that. So we started a small series with Regeneten, but must admit that quite a few complications happen for which they become too stiff. And then with the high cost, I really stopped that study, and we are not doing it anymore. But I wanted to share this evening that this is one of the options available, part of the repertoire that you can use. A cheaper option would actually be ADM or dermal allografts. Dermal allografts really just provide a tough scaffold, but they're not biologically so inductive. So this is an example of our elderly lady with a previous repair. So take note, it is a revision, and therefore the tendons may not be strong. They are subjected to slight degeneration. So right shoulder pain and MRI degenerate tendon thin out. So that's when I want to build up, so to speak. Yeah. So we see this. It's not a very big tendon, not a big tear, but the tendons are really almost paper thin. Yeah. So I really needed to fortify it, to strengthen it. So I pass sutures first, both antegrade and retrograde. So this case is antegrade. I pass sutures, tucking it in deep medially. Having parked the sutures, I measured them, yeah, and so I can shape and size the ADM or the dermal allograft to size. I then slide them in, and I tie the horizontal sutures placed earlier. And then I crisscross the sutures and place them to lateral row anchors. It's very, very simple way. So you see a very nice crisscross pattern. Yeah. So I found this ADM very, very useful adjunct in many small tears. I see it looking degenerate, thin. I apply that. The cost is remarkably low compared to the Regeneten. 10% of the Regeneten costs. And we shared this technique on the arthroscopy techniques some time back. So we've seen Regeneten, we've seen ADMs, in addition to PRP gel. But when I begin to think through, Regeneten is biologically incredible, but really weak at time zero. ADM or dermal allografts is strong at time zero, but may not be biologically active. Is there something that combines the best of these two? I think BioBrace is possibly a mixture combining the strength of these two, strength at time zero and yet biologically active. I'll show you what it is. So BioBrace is highly porous type 1 collagen scaffold. Now, it is known to be to have good bioinductivity, but what makes it slightly different? It has this PLLA monofilaments embedded into it. That gives it that strength. So it is both a 3D scaffold to allow host induction and maturation of tissues, but it allows load sharing at time zero, and that's important for us. Yeah. So it can be used in single, double, transosseous repair. And we quote studies done by Walsh in sheep. They use BioBrace, which looks like that, and the infraspinators, which best mimics the human supraspinators. Very nicely at 6 weeks, you can see slide A to B, you can see infiltration of the fibroblasts and fibrovascular tissue. By 12 weeks, there is maturation of and remodeling of the fibrovascular connective tissue. At 12 weeks, the repair with BioBrace is as strong as the contralateral normal tendon. So we have confidence it's biologically active and mechanically strong. How does it compare? As I've alluded earlier, Regeneten is great. Type 1 collagen fibers acts as a scaffold, great biologically. But unlike BioBrace, it does not provide the structural strength at the time of implantation. Not to mention that the high costs, because each market is different. In Singapore and India may be priced differently. But yeah, Regeneten is rather expensive. How does it compare with dermal allograft? Dermal allograft, as you know, is really strong. ADMs has high tensile strength of up to 20 megapascal and a suture retention strength of roughly 100 newtons, which is incredible, more than enough for repair of cuff tendons. It increases the load to failure at the time of implantation. But really, biologically, it increases time to tissue incorporation, risk of allogenic tissue, and whether or not it really encourages tissue growth. We don't know. Before I had access to BioBrace, I was happy using ADM because post-op scan shows the thickness, increase in thickness. But now we are waiting whether BioBrace can deliver what it is supposed to. Let me show you by example how I use it. So this is 59-year-old lady who works in our operating theater, right shoulder pain for 6 years. Initial ultrasound scan just shows tendinosis. After intensive physio, repeat MRI now shows tear, which is increasing in size. So examination shows limited ROMs and definitely weakness limited by pain. So classic. When I look through her MRI, you can see a significant tear, yeah, but not too bad, yeah. In the past, I would ordinarily just repair this, but now I think we should augment this biology in view of the chronicity of the tear, not so much the size, chronicity of the tear, but also the potential degeneration of the tear, of the tendon. So a good clearing of the SAD, and then identifying the tear, I place my medial row. This tear is quite small, so it's good time to start. And then I debride and I make sure the tendon is easily repaired. I then plant my medial row sutures. I first measure to get an idea of the size of braces that I want and apply very medial sutures. So white sutures anteriorly, and then I tuck them away. And then blue sutures posteriorly. Yeah? So I tuck all the medial row sutures, which is to take in the BioBrace later on. And then proceed to repair the suture, the tear, with simple Mason Allen stitches. So that's going up. This is coming down, creating the horizontal component of the Mason Allen, and then transfers across the horizontal patch. Then once tying it down, it's a classic Mason Allen. I then prepare the BioBrace, which looks like that. I put luggage tags at the two ends. Then just before insertion, I douse the whole thing with iodine, especially the skin, because to avoid C. acne infection. As the BioBrace is inserted and tucked in, then slowly I tie the posterior blue sutures and then the anterior white sutures. Yeah? So the BioBrace is held down. And then I tie the lateral row anchors, anterior and posterior. When the luggage tag sutures right at the edge and in the medial sutures tight as shown with a crisscross configuration, very easy, very predictable. Yeah, so we've been doing this in patients with elderly patients, revisions, and degenerate tendons. So I do early scans to see what it looks like, and I'm hoping to do much later to see whether there's biological incorporation. So it's really something, an ongoing study. These are early scans. You can see the BioBrace layer is still intact. And so far when we begun this series just this year, most of them are medium to some larger tears. Very nice reduction in pain by 6 weeks, improvement of ROM, forward flexion, abduction, and our scores. So it's very promising. We're looking forward to that. So in terms of cuff repair, what role does orthobiologics have? What have I learned? Tears are common, but they don't always heal. One of the biggest injury, of course, is our ego, to realize that our cuff tears can fail. We've understand better, a little better, the mechanics of cuff repair with every study we do. But we know that biological healing remains a challenge. And that's why the focus of our recent research and trials is really towards biology. Injections like PRP may suffer this dilution effect. Yeah? And what I think empirically, it's not concentrated at the repair sites. And that's why we tried PRP gel at the repair site and provides us with ideas of how do I deliver something right at the repair site. And it must stay there. That's the challenge. I've shared with you Regeniten, possibly ADM, and what I believe that combines the best of both biology and mechanical strength, BioBrace, which is what we currently use and part of our ongoing study. So on this note, I thank you very much for this opportunity to share some of the techniques that I use in improving healing of my rotator cuff repairs. I'll be happy to take questions, or we can ask our second speaker, Dr. Jain, to go ahead, and I'll stop sharing here. Thank you, Dr. Jain.
Uh, Thank you, Dr. Danny, for giving such a wonderful insight. Uh, expanding the horizon of orthobiologics from PRP gel to uh, BioBrace and multiple the multiple products which are there. So, Dr. Sandeep, you want to add few questions, or I have
Yes,
two questions for Dr. Danny?
yeah.
Please.
So can I go? So Dr. Danny, it was excellent talk. I mean, like the comparison which you have shown, I have never heard in any of the conferences because people speak about only one technique or something like that. But you have very nicely elaborated. So I just wanted to know how do you decide about type of procedure, orthobiologic procedure Is it the age of the patient, tissue quality, or the type of care? What
Great.
exactly?
Thank you. Thank you, Dr.
Okay.
Sandeep. Ideally, I want to use them in the large tears. Ideally, I want to use them in revision and in cases of elderly patient which are known to have degenerate tendons. And I preface it with the word ideal because sometimes it's very hard to predict them. Yeah. So to me, the red flags are definitely age of patient, and if I can detect thinning out degeneration at the pre-op imaging. So the moment these two light up, I'm prepared for um, some of these biological augments. But sometimes I find them on during the time of surgery, the cases where you see very frayed, very thin out. So that's when I tried to augment them either by bursal augmentation, PRP gel, or ADMs. The thing is that I don't use Regeneten because I have to prepare for them and they're quite expensive. And so is BioBrace. So what is at hand off the shelf anytime I use are usually the ADMs and the gels. Um, so really I'm guided by age, chronicity, and thinning out. Very classic indications. Nothing too different. But the tear size is what I'm griping with because ideally we want in revision and precisely in large tears where healing is a challenge. But in these large tears, it is also very difficult to apply some of these biologics. The temptation is to create a mechanical repair and then hoping for the best, just inject something that will heal. Yeah.
Right.
Uh,
So,
Yeah.
for BioBrace, one question.
Hmm.
Can we just do the partial repair and use it, or even can you use it if stuff is completely deficient? As
Hmm.
you mentioned, it has got a very good strength as compared to all other ADMs, even better than Regen 10.
Yeah, so far our evidence is that it's really a little bit better than the previous two. I've described several ways of using BioBrace, one of which is you can ignore the tear and then just use BioBrace to cover it. But most of the time we try to repair the tear first and then use BioBrace as an augment over it. That's a little bit complicated because you need to anticipate and then plan the sutures ahead of time. If, however, I repair a tendon first and then I want to add on a BioBrace, you can still do that, but a little bit tricky because then you have to add an additional lateral roll. Yeah, so it's just to me a matter of pre-planning if you want to do it.
and may I ask you a question, Dr.
Thank
Lee?
you. Thank you.
Thank you.
How how this orthobiologics introduction in your practice have changed your personal clinical outcomes?
Mm. So what we've noticed, Dr. Jain, is one is that state of first and foremost, I would say the effect on us, the caregiver, and the effect on the patient. The effect on the patient, we see definitely less pain or earlier, more keen rehabilitation because of pain that is a little bit less than before. And does it translate to better strength? No, but functional outcome, yes. So they achieve reduced pain reduction a bit earlier, and hence functional outcome a bit earlier. Some of the BioBrace as early as a few weeks seems to be really, really happy.
And what about re-tear rate?
So far in our series, I mean, we're just monitoring it. In our series of blinded post-op imaging, we do have some retails, as I admit. Interestingly, they are the ones without any augmentation because we're doing different augmentation, as you can see. So I'm not saying that, oh, augmentation definitely cancels out our retears. No, but we're still analyzing what factors cause that. But I want
Interesting.
to add that sometimes some of these biological augmentation gives us, the caregiver, that additional confidence, both in post-op visualization of the integrity and knowing that the biological environment is improved. Yeah. So I would say that in this early stage, we are a little bit more confident. We're seeing an improvement overall.
Any questions from Dr. Daniel
Sir,
side? Dr. Amit?
sir, I have
Yes.
few questions, sir. Suppose there's an associated condition like a frozen shoulder or adhesive capsulitis
Hmm.
or a osteoarthritis of the shoulder in a long-standing tear in elderly patients. So what's the protocol of the treatment? Do you still repair or you first treat the associated condition?
Thank you. So in adhesive capsulitis, I think I would avoid all forms of biological augmentation. And maybe this may be anecdotal, but when we first started Regeniten, its bioinductivity was so high that we saw a swing towards adhesive capsulitis. So we think that if a patient has somewhat decreased ROM due to some thickening of capsule, which can happen in the context of a cuff tear, I try to avoid augmentation. I do not want to incite further reaction, so to speak, that might worsen that component of their problem. If, however, they have, like you said, arthritis, Dr. Amit,
Yes, sir.
I'm not sure the role of repair or biologics. Um, if they're young, uh, arthritis, say secondary to trauma or something, maybe I might try. But in general, the ones who are older with cuff tear and arthritis, I think I would really go for a replacement. And RSA is really good outcomes
Yes.
for them. So in some of them, we tried to repair and all forms of biology, especially those who do not want replacement. And surprisingly, even in Singapore, where they do have insurance, some of them just don't want replacement. So, okay, that's when I have to struggle with all forms of injections or replacement to temporize their pain. But it's not a long-term solution.
Agreed. There are a lot of taboo associated with many persons, irrespective of they have money or not, about the replacement.
Yeah, that's
Dr. Daniel, I think you had a question.
Yes. Yes, at least in my country, these procedures are not covered by insurance. So I would like to know if there is really high level evidence to support the massive use of this, and if there is a really significant difference in the outcome, because in my experience, I have been involved repairing a rotator cuff for the last 35 years. Uh, Postoperative pain, especially after the use of the block, the anesthetic block, is not a big problem for us. So how can I make the insurance believe that it is worth to cover these procedures?
great. Thank you, Moya. So, as far as I know, are there big prospective studies to prove that either Regeniten, ADM, or BioBrace can improve quality of life, prompts, and hence added value for the insurance? No, I'm not aware of them. There are many uh, studies, small to large, prospective, retrospective, that shows improvement indeed, either versus controls or versus each other. But does it really, really translate to an improved quality of life, or prompts that would add value for the insurance? I'm not so sure, Dr. Moya. Yeah,
Good.
so that really requires a big long-term study. And if we're really, really honest, then we said, I'm not sure. I don't think so.
Thank you.
So, but
Interesting.
here we are trying to, as it were, understand why some of our cuff tears fail, despite what we think as sound mechanics. And how can I improve that biology?
You know, what we learned
Hmm.
from shockwaves is that generally we are just relying on indirect information about the tendon. We check how is the belly of the muscle, the age of the patient, but in fact, the, there are not many classifications about the tissue quality of the tendon. It is not easy to evaluate that. But there was a very interesting paper by some friends from Chile, very interesting, that was published in the British Journal of Shoulder and Elbow, in which they treat a group of patients that were scheduled for repair of the rotator cuff with shockwaves 3 weeks before surgery, and another group, the control group, with no shockwaves.
Mm,
And they performed biopsies during the surgery. And they realized that those patients in which the degeneration of the tendon, according to Riley classification, was mild or moderate, they have a reaction. There was a developing of neoangiogenesis, even lymphoangiogenesis. But in those that have an advanced degeneration, there was no reaction. And that was really significant comparing to the ones who do not receive shockwaves before. So one of the things we learned is that there are tissues that are in such an advanced degeneration that will not react whatever you use, and there is no correlation between the size of the tear, the age of the patient, and the quality of the tissue, the tendon tissue. So that makes it tricky to know in advance what will happen. And I think that's one of the gaps we need to fill.
yeah, thank you, Dr. Moya. And do you remember there was a time when there was this microtenotomy, radio frequency pulsing?
Yeah.
Yeah. That too was touted to improve neovascularization, improving the signal. And that was popularized for tendinosis. Do you remember at one point? Yeah. Um,
Yeah.
so I fully agree. Any form that could excite the tissue for this regeneration, neovascularization, should be not closed. It should be an option for us, be it from shockwave, radio frequency, anyway, or injections of biologics. I agree. The whole idea is to improve the biology. The question is
Mm,
how, which is cost effective and,
Yeah.
that is precisely the reason we all are sitting and discussing, because
mm,
we all are into the rotator cuff repairs, and two most dreaded complications is the pain post-operative, reduced range of motion, and re-tear. So
mm,
whether we use shock waves or biologics, the idea is to have a better patient outcome in the terms of both radiologically also and clinically also. So I think it was a interesting session delivered by Dr. Danny. So Dr. Amit, shall we proceed further?
Thank you, Denny Lie, sir, for your talk. Now, proceeding with the second session, I invite Dr. Karun Jain for his talk. He is MCH from the Royal College of Surgeons, Edinburgh, UK, and he's also a fellow of American College of Surgeons. He is currently a senior orthopedic surgeon, Pushpanjali Medical Center, and is a director of Shri Mahavir Orthopedics Hospital, Delhi. He has a vast experience in the field of trauma surgeries, orthobiologics, joint replacement, and other orthopedic related diseases. He has been a national faculty and a pioneer in establishing orthobiologics and regenerative medicine in India. He has a keen interest in medical research with many national and international publications. Dr. Karanjan, kindly proceed for your talk.
Yeah, thank you. Thank you for the kind introduction, Dr. Amit. So with everybody's permission, I'll share my screen now. Yeah, so is it visible to everybody? Full screen?
Yes, yes. Dr. Karan is visible here.
Yeah, so I will continue after the brilliant talk by Dr. Danny Lie and his arguably the one of the interesting talk. So since we are practicing in India, I am here to present a indigenous way or more cost-effective way by which we can try to improve the outcome of rotator cuff repair. So the idea is to use of effect of growth factor concentrate augmentation in rotator cuff repair. This slide I show it to everybody and in all the webinars that orthobiologics is not a magical entity. It is a procedure. As Dr. Denny Lie said, all orthobiologics are not for all the procedures and not vice versa. They has indications, contraindications and limitations. And the most convenient way of teaching, which we all understood from our PG days, is treating the non-union by iliac bone graft. And mind you, that is also a orthobiological procedure. So we have different varieties of the orthobiologics. We are like PRP, GFC, other preparation. We have BMAC, fat cell derivatives. Now so many implant companies have come up with a lot of products, which Dr. Denny Lie also said. We have BioBraces, we have Arthrex and Smith and Nephew have come up with the huge range of orthobiological products for knee and shoulder surgeries. There are so many athletes who have undergone biological treatments. Tiger Woods, Kobe Bryant, Maria Sharapova. There are n number of athletes who have undergone the biological procedures. So coming to the rotator cuff repair, despite being it's the commonest shoulder pathology, the treatment of shoulder rotator cuff is still having lot of hurdles because of two main problems is the painful outcome and re-tear rate. So the goal of the treatment is to achieve pain-free
Sir,
shoulder with a good outcome.
Dr. Karun, this is not moving. The slides are not moving.
Yeah, I'm not moving it. Yeah. So,
You are not moving. Yeah. Because
Sir,
someone
and
ready from the
please make it
Ortho
in
TV
full
also
screen
said,
mode.
yeah.
okay. Please tell me, Poonamji, you were telling something?
Sir, slides are not visible in full screen mode.
Oh, not visible in full screen mode. 1 second. I'll just stop sharing and I'll I think now you can see full screen mode.
Yeah,
Yes,
now
sir.
it's fine.
Yeah. So, as I discussed earlier, the two major problems with RCR is re-tear rate and the satisfactory clinical outcome. A lot of papers which says that outcome and the re-tear can varies from 13% to up to 94%. So, what we can do along with RCR, so the lateral thinking we utilize is using the growth factor rich concentrate injection so that the better outcome can be achieved. Yes, as Dr. Danny Lie, Dr. Moya also told that the anatomy or the biology of tendon is not very well understood or poorly understood. So whenever we do the repair, we actually achieve a disorganized fiber scar tissue supported by the suture threads. So it is inherently weak repair. So if we add biology, we can try to organize the tissue in a better healing way. There are a lot of procedures which are there. I will not go in the details because Dr. Danny has already covered. So coming to the R study of using GFC augment in medium to large rotator cuff repair. So what study design was? Inclusion criteria, a repairable full thickness tear, patient willing to undergo randomized controlled trial, adequate resources for MRI, and exclusion criteria were failed fractures, cuff tear arthropathy, extension of tear to subscap tendon or isolated subscap tear, degenerative arthritis, irreparable tears, and previous surgery to shame shoulder. So either we have done a single row repair or a double row repair. It's the standard way which we have done, all the arthroscopic way. And we have injected a growth factor rich concentrate injection with the help of spinal needle. It was inserted approximately 1.5 centimeter anterior to the lateral portal at around 15-degree angle to allow penetration at the repair site, and we have injected under arthroscopic guidance. So first injection we have given in an arthroscopic view, and second and third injection we have given in OPD setup. So what Dr. Denny was telling, that yes, there are chances whenever you inject, there are chances of dilution or wash out of the growth factor rich concentrate. So to overcome that, we have incorporated two more injections on the 15th day and 30th day, so that a repeated biostimulation can be given to the tissue. Primary outcome was measured by the DASH score and VAS score. Fatty generation of RCR repair was noticed. MRI was performed at 3, 6 and 12 months, and all patients completed DASH score and VAS score independently. GFC, I will not go in a deep detail because it's an autologous preparation and it's an advanced form of PRP. Standard procedures are there for collecting of PRP or GFCs, and this is the way of making indigenous GFC. So you take the whole blood, you put it for the centrifugation, double spin technique I am talking about. After first spin, you take out the buffy layer along with the supplement plasma, and when you put it for the hard spin, the final product which you get is the leukocyte rich PRP. So that leukocyte rich PRP is the growth factor rich concentrate which we are using in our all the surgeries. That is a dual spin technique, no adulteration of the product. Standard statistical analysis was used. So our study was not very big study. There is a small study, 10 patients each. One patient's group 1 had RCR repair alone, and second patients had RCR plus GFC. Mean follow-up was for 15 months. Now it is around 2 years, but when we completed the study, it was 15 months. So as you can see, the dash score, constant score, VAS score, forward flexion and external rotation, all parameters improved in group 2, which were statistically significant. Internal rotations also improved, but it was not statistically significant. But we were happy to see the outcome of dash and the constant score. When we talk about results, I told that scores improved. Overall, patient's range of motion improved. Out of 3 subjects of group 1, who 3 subjects had re-tear in group 1 and none of the subject had re-tear in group 2. Group 2 is a GFC group, mind you. Group 1, where the patient who had 3 re-tear, one subject had to go undergo a repeat surgery because of his symptomatic painful shoulder. So these are the few examples which I want to share. This is a 65-year-old gentleman. At the 3rd month, you can see the footprint is getting covered, and at the end of 12-month, footprint is completely covered with the tendon. This is his range of motion post-operative. Second, again a 55-year-old lady. I have undergone multiple GFC injections, and you can see post-operative the lower right corner slides. Tendon shows type T3 pattern with homogeneity, low S1 and 12-month follow-up of the study. This is her range of motion. Third case, a 49-year-old male who has given GFC injections, and again you can see in the right side slide, at the end of 12-month, tendon attachment is covering the entire footprint, augmented with 3 GFC injection. This is his range of motion. So what are the study conclusion? So these biological injections are very cost effective. There are hardly few dollars if I talk about international way, and in India it's hardly less than 2 to 3,000 rupees. And we are giving, it's a minimally invasive, it's from the patient's blood, so we have a least side effect, but they do increase the outcome, they improve the outcome of the cases. So my question to everybody is, why not to use it? This is our again one more indigenous method which we are using, ab gel. As we are aware, this ab gel is available in all the OTs. So one way of Dr. Denny told is making PRP gel. The another way which we are using nowadays is using the ab gel. We soak the PRP in ab gel, and with the help of probe, just before suturing, just like PRP gel, we are putting the ab gel, and then we do the repair, lateral row repair, so that abgel get incorporated at the most important tier site. So first we give abgel, and after 15 days and 30 days we are giving the standard GFC injection. So we have a localized approach with a generalized approach. So it's a mixture of the approach, and we are getting decent results. Hopefully we will be able to publish this study in future, and this will, will be a give a lateral thinking to my all learned viewers also. So coming to the evidence, there are so many articles which are there now. This is article by the American Journal of Sports Medicine, RCT. They concluded the similar findings which I was advocating. It's a level 1 study. Second article, again they had given this PRP injections after double row repair of arthroscopy RCR repair, and they also told that it's a novel technique, the outcomes are good, and the re-tear rates are less. This particular study I want to highlight with everybody. This is published in Arthroscopic Sports Medicine Rehab Journal 2022. It's quite a recent study. And why I want to mention this study? Because most of the studies which we have, the sample size is quite low. So we argued always, I believe that orthobiologics is an evolving science. And soon, what Dr. Denny and Dr. Moya was telling, soon we will start getting evidences, maybe in favor. But this study had a sample size of 1,800 patients with an average follow of 1 to 3 years. So this is a good number of subjects, 1800 patients, and they categorically concluded that PRP is effective in reducing the re-tear after RCR repair, and it helps in improving also in the outcome of the patients and reducing the short-term pain. So overall, the things, the operating biological interventions are improving nowadays. Maybe because of the better techniques, maybe because of the better production of scaffolds that which Dr. Denny was telling. So now we are getting good studies which are coming in favor of orthobiological intervention. So to conclude, GFC augment is effective in reducing re-tear, improving functional outcome, and since it reduces the re-tear, though economic burden to the society as a whole is less, because we still don't have lot of insurance driven patients in India. We have moderate, what you say, middle class population, and if we can add any biological procedure by which we can avoid the second surgery. So my question to everybody is, why not? Why not to intervene? So with this thought, I conclude my session, and I invite all the viewers for second Delhi Orthobiologics course, where we will have an in-depth discussion of various orthobiological cases and products and everything. So with this, I end my session, and I open the session for question and answers.
Thank you, Dr. Karun, for your exhaustive talk, and now the topic is open for discussion, sir. My one question, you said that GFC concentrate on the first day you give arthroscopy and the second and third injections you give in OPD. How you decide about the site of the injection in OPD?
No, yes, this is a very good question. The first injection, since we are giving under arthroscopy, we give in a lateral way only.
Let
But when we give second or third injection, we give a standard posterior way of entering in the shoulder. Plus,
standard
we give a little higher volume. We are
higher
not giving
volume.
2 to 3 ml. Now we are giving 6 ml. There is a little higher
6
volume
ml.
which we are giving, so that the chances of washout is little less.
You said that. So it is beneficial. Ideally, if you give single, and there are studies regarding if you give single or and you give another two in
Well,
OPD, they have any evidence regarding that
yeah,
the
well,
three are better as compared to first?
this idea came with the lot of orthobiological studies which are there for meniscal repair. So since meniscus does not have its own blood supply, there are so many studies where they are giving this 0, 15 and 30 protocol for meniscal repairs. So with this thought, Since we prepare the GFC in-house and it does not involve a lot of cost, and patient usually come at 15 day for suture removal. So one injection we give that time and at 30th day on the follow-up. So without increasing the cost or financial burden to the patient, we are giving this injection, and we are still on the learning phase. Just because I am delivering a talk, I am still a student of science. I want to learn. I am enthusiast. I want to learn with my colleagues. So we are getting good results. Let us see how the future gets shapen up in near future about this.
Thank you, Dr. Karan.
So shall we have any further questions or
Hey, Dr. Jain, can I thank you very much for your talk. Can I continue the discussion about your
yeah, Dr. Danny, over to you.
Can I ask you how much blood do you draw at the time of the injection? How much do you have to use?
I am using a hyperacute serum technique. So we are withdrawing around 20 ml.
Mm,
So out of 20 ml, we are able to get 5 to 6 ml of the GFC.
mm, okay.
Anything which is more than 4 ml, because you know that sometimes RBCs are more, sometimes we don't get a good amount. So any amount which is more than 4 ml, I accept that. But if we get less than 4 ml, so then unfortunately we take little more blood and wait for further. So anything more than 4 ml of GFC is a good for me.
Mm. And you use leukocyte rich.
Yeah, leukocyte rich, not leukocyte poor,
Mm,
because I want to actually create inflammation. Just to add a point of this biologics, these are pro-inflammatory. So idea is to create pro-inflammation to the anti-inflammation and the healing effect. So
yeah.
we have to, what Dr. Daniel was telling, by any way, if we can stimulate the tissue for healing, so we can argue that we are creating a biological environment. So this is my thought, and Dr. Danny and Dr. You can put more thoughts over it.
The tear sizes, were they roughly the same, Dr. Jain? The tear sizes of your patients?
Yeah, nearly all the same, and most of the patients which we gave the shot of this GFC, they all underwent double row repair
Mm,
because the size was big.
yeah. Can I ask the broader context of biologics in India? The use of stem cells, is it legislated? Is it legal?
Well, stem cell is not permitted,
Mm-hmm.
and stem cell is actually a different ball of game.
Mm,
When I am talking about acellular therapy, acellular therapy, which is just PRPs or GFCs or hyperacute serum, which are done in the same sitting and minimally invasive and given to the patient at the same time. So stem cells, yes, there is no permission, even though one of the pharmaceutical company have bought a stem cell injection, which is by the permission of government of India, and interestingly, lot of insurance are also covering that. But clearance of stem cell, there are still a lot of gray zone, because when I say that stem cell is not permitted, so that pharmaceutical company say comes and with the product and says, look doctor, this is permitted, we are here with permission of the government of India, we have insurance coverage. So as a clinician, no, but as per the pharma company, that pharma company, yes. But for PRPs or GFCs, which are acellular therapy, single sitting therapies, these are there.
great. I raised this up because this idea of multiple injections that will help to improve and accelerate healing. There is a big group in Malaysia that uses stem cell, and then they give multiple injections into the knee and demonstrating with histological evidence the growth of cartilage, which was like, whoa, I didn't think it was even possible. And they seem to have very promising results. Okay, but I've not seen it in the shoulder, of course. Certainly not with tendon. But the question is, Is it the effect of that multiple injections? Of course, they use stem cells. In Malaysia, the legislation may not be so tight. In India, it's not allowed. In Singapore, it's not allowed. So I can't prove or disprove it one way or another. But would multiple injections of, say, PRP or growth factors, will it really steer the outcome? That's very interesting. But thank you for
Well,
your insightful study, Dr. Jain. Dr. Moya, your thoughts on this?
Well, I am learning a lot and I am very happy with this. I think this is promising. As we said, we need to prove with big amounts of patients. But as Dr. Jain said or presented, there are coming up some studies with a big amount of patients. In our country, for instance, talking about stem cells, they are allowed to be used in blood diseases, and there is research going on knee osteoarthritis, but the other projects, the other research projects should be free for patients and communicated to the health agencies. But unfortunately, parallel to that legislation, there are many people offering the magic cure for osteoarthritis and things like that. So it's a pity in all these new fields that we need to fight against professionals that are not doing things well and in some way are putting these topics in a level of discussion that is not the best one. But time will prove the effort of physicians like you both trying to show in a scientific way the advantages or disadvantages of these procedures. I think that's the way.
just to give a concluding line about osteoarthritis of the knee. Well, I always say that osteoarthritis of the knee is a never-ending disease. It is a degenerative disease. So whatever we do, whatever intervention we do, it is gonna come back. Whatever you give any injection, stem cell, cartilage repair, because you cannot do anti-aging to the knee. So the idea of propagating orthobiologics is any indications other than the osteoarthritis of the knee, because it hurt a lot of sentiments to lot of orthopedic community. See, just like adding shockwave therapy in many tendon injuries, like adding rotator cuff repair with orthobiologics. So this way we can improve the outcome and a permanent outcome. Once a tendon of RCR is healed with the help of biologics, so patient is completely recovered. Problem with osteoarthritis knee, there is nothing called completely recovered. So that creates a hostile environment, because it's not a complete, whatever injection you give, whatever therapy you give, there is no completion to this disease. So with this thought, food of thought, I am concluding my remark. So if Dr. Danny and Dr. Daniel permits, so should we conclude this webinar?
Yeah. Can I
Well,
just ask,
yes.
the panel's opinion on something quite related to rotator cuff repair? Bursal tissue. When we go in and the subacromial space, we see quite rather inflamed bursa, and we tend to shave them. We need to, in order to visualize, in order to repair the tendon. What are your thoughts? Is bursal tissue good or not good for healing?
Along the years, there was a change in the approach to this. We used to uh, take all the bursa, saying it will form again,
Mm,
and we just try to took it out, considering it was a tissue that was inflammatory, chronic inflammatory tissue, part of the reasons for pain in the patients. But some years later, it was said that the bursa was the origin of the cells that were going to repair the tendon. So it was good to keep it.
mm,
So I think that, as far as I know, the idea now is to try to preserve the bursa, not to extract all the bursa. But there are the ties of knowledge that are coming and going, and there are many things that across the years I have seen that there are different positions. I don't know what is your idea. It's very interesting what you asked.
Thank you, Dr. Maya, because I wanted to
That
ask you with the perspective of your vast experience. Mine is less than yours, but even in my short practice, I noticed that change. Where I was taught to clear everything, saying that, hey, that causes the pain. So I need to clear. And, the satisfaction of seeing clean tissues before I repair.
Yeah.
But I realized over the years that, hey, those clean tissues are precisely hypovascular. So how are we going to heal? And then the shift we've seen, how people believe the bursa is actually healing tissues, the cells, and the vascularity. So there's a move to preserve them. What I try to do is either not remove as much, and sometimes
Mhm.
the final stitch, I tuck them like a duvet or a blanket over it. And there's another way of debriding them by collecting whatever to be debrided, and then I put them into a gel, Dr. Jain, and then you layer it back to them.
Oh, that
It's
is
like,
very interesting.
yeah,
Yes.
so it's like, hey, I've removed them, and now I put them back. Yeah, you know what I mean? So really, our thoughts are like pendular. They swing back and forth.
Yeah.
But
Yeah.
if I believe that the bursa is really good for healing, and that's what we're trying to show, I debride, I put them into a gel, and I put layer over it, and I track them with scans and prompts, and I compare with and without the bursal thing. The
Good.
only thing I can't do is biopsy because it's not easy to get that as ethical approval.
But
But
I think you are adding a new dimension to the
yeah,
orthobiologics altogether.
if we rethink, are the healing tissues actually already there? We've
Hmm.
taken away, but it's already all the while there. So where are we going with this? So maybe I raised too many questions this evening, but something to think about, the
Dr.
possibility.
Karun, what about your this take on superdose PRP? There are a lot of studies regarding PRP and superdose, which is about double the dose of PRP. So in knee
Well,
osteoarthritis. So what about in rotator cuff?
yeah,
Superdose PRP?
yeah, this clinical thought is going on in various literature and various article. See, whatever you do, whatever you label it as a superdose PRP, you label as a growth factor rich concentration, or you would label it as a hyperacute serum. The idea is to get a good quality PRP with we have a good concentration of platelet, good concentration of growth factors. So whatever name you label, if you are doing it, making it right, it's good enough. So it's, I think, again, super dose PRP. I don't know. For me, it's just a eye candy to me. Uh, I don't know. So Dr. Danny, you have anything comments on this?
Many studies are in literature regarding superdose
Yes, I know,
PRP.
I have, I came across with many studies, but
Mhm.
I feel if you are doing it good, it's like tibia fracture. If you are nailing it, if whatever implant you are doing, if you are reducing the fracture right, you will get the healing. So whatever product and whatever way you are making it, if you are making it right, you will get the result. So this is my personal thought. Uh, I don't know whether super rich PRP or super dose PRP is there in Singapore or not. So Dr. N is there?
So there is what they call the in strike, where we super spin second round the PRP to give it really more concentrated. And we're even looking, what if I add some specific cytokines to direct certain type of healing? Well, that's not completely legislated yet, but super spin PRP or in stride is available. Unfortunately, it's a little bit expensive.
But I'm using that only, double spin.
Yeah, I mean, indigenous one, it's okay if you do it on your own. Um, but as far as the Instride or the Superspun PRP for knee arthritis or knee conditions, I'm afraid there's not much hard data there. I think it's still industry driven, if you ask me, to prove one way or another. Yeah,
Yeah, I think.
got to keep all that balance in mind because the one factor that we did not discuss this evening is actually costs. Yeah. So, okay, maybe another day.
Yeah, I think another day. So any further questions? So with this,
None from me, but thank you very much.
so thank you, Dr. Danny, for such a insightful thoughts. Thank you, Dr. Daniel, for joining, and thank you so much, Dr. Sandeep and Dr. Amit, for joining this webinar. I am hopeful that we have done justice to this talk, and our viewers and our fellow orthopedic surgeon can take home something about orthobiologics augmentation in rotator cuff repair. So next month we will come with another episode, another disease, another orthobiological indication. So till then, stay tuned. Good night. Do take care of yourself. Bye bye.
Thank you.
And
All right.
thank you,
Thank
everyone.
you.
Nice
Thank
meeting
you.
you.
Good night.
Bye
Bye
bye.
bye.
Thank you. Thank you, Dr. Sandeep.